I'm just going to kind of give a quick outline of what, there we go. This is just a quick outline of what I'll be discussing, and then Laura will talk after me. So I'll just sort of go over basic anatomy of the knee just to kind of orient everyone as to the things that we talk about. And then I'll touch on different types of knee pain, and then I'll talk a little bit about common causes of what we call atraumatic knee pain. And then we'll kind of hone in on something that I think Laura and I both see quite a bit of in our practices, anterior knee pain, or what we call patellofemoral pain syndrome. And then sort of Laura will kind of dive into that a little bit more in terms of her approach of treating this. Okay, so basic anatomy of the knee. So there's sort of four components to it. The bones, obviously. So we have the femur and the tibia. Femur is the thigh bone, tibia is the leg bone. I mean, the fibula is also part of the leg. It doesn't really articulate with the knee joint, so we don't really talk about that as much. And then, of course, the patella or the kneecap. And those are the main things that we can see on x-ray. So when you come to see me and I get an x-ray, I'm looking at bony elements of your joint. You can't see cartilage, although cartilage is empty space on x-ray, and so it can give us an idea of arthritis. But otherwise, any other structures, ACL, PCL, menisci, any of that, you can't see on x-ray. And we have the ligaments. So we have the two in the middle, which are the anterior cruciate or ACL and posterior cruciate PCL. We have the MCL, which is the one on the inner part of the knee, the medial collateral ligament, and the LCL, which is on the outer part of the knee, or the lateral collateral ligament. And then there's some hamstrings that are involved in sort of knee mechanics and function, tendons that are involved. And those are primarily the hamstrings, the quadriceps, and the patellar tendons. And of course, then we have cartilage, two types of cartilage in the knee joint. So we have the articular cartilage, which is the kind of what I always say is the chicken bone cartilage. You see it on the end of chicken bones, and we have that as well. And that's what's primarily involved in arthritis. And then we have the menisci, which are also made of cartilage, but act like little, almost like cushions in the joint. Okay. So a couple of types of knee pain that I always, when you come to see me in the office, I sort of separate your presentation or your issue into traumatic versus atraumatic. Traumatic knee pain is basically, pretty straightforward, associated with some sort of injury or an event. Usually the patient will say, this happened and that's when my pain began. So it's a very sort of direct correlation between something happening and the knee hurting. Most often it's sudden onset, so we call it acute pain. Certainly can lead to chronic pain if it's untreated, or even if it is treated, unfortunately. And then atraumatic pain is more often it's sort of insidious onset, no real specific injury, just kind of comes out of nowhere with no real reason. And when patients come to me with this type of pain, it's usually chronic or presentation, meaning it's been going on for a while and the patient's been trying to manage it on their own, and then finally decided to come in and get some help. So common causes of traumatic knee pain. Again, I apologize if this is very basic, but I think it's really helpful to kind of separate this out in your mind. This is how I approach anyone that comes in to see me in the office. So common symptoms of traumatic knee pain, obviously you'll have swelling. A lot of times I'll say, a swollen knee feels like a balloon. Like you try to bend it and it feels like you're squishing a balloon, or it can feel a little boggy and heavy, and that's usually a sign that there's swelling inside the joint. Versus sort of soft tissue swelling, for example, if you have a bruise and the tissue in that area is swollen and tender. Of course, you can get some bruising. It's not that common with injury to the actual knee joint, but I have seen some injury with some bruising with severe injuries, or if there's been a direct trauma to the area, and some redness as well. You can get a little bit of that. Obviously, there's sharp pain. A lot of times the patient will be able to take one finger and kind of point to where it hurts, and that usually indicates that there's been a traumatic injury. Sometimes not as much, but that's usually a helpful thing. Oftentimes your inability to bear weight, the knee will feel unstable. This doesn't necessarily mean that there's been a ligament injury. Instability can also come from pain, or if there's swelling in the knee, the muscles that I mentioned, like the quadriceps and the hamstring, can't aren't sort of at their efficient length, if you will, and so they can't protect the knee, they can't keep it stable, and so it'll feel like it's giving out. And then the final thing that I look for is mechanical symptoms, which is clicking, catching, sensation like something's getting stuck in the knee or something is shifting in and out of place. Those are all sort of things I look for that might guide me into getting some more imaging. And so, of course, all these things make me think of a meniscus injury, cartilage damage. You can knock off a piece of cartilage in your joint, ligament injury, or sometimes a muscle injury, although that's not as common. And then this often requires additional imaging. Usually an MRI, sometimes a CT scan for fractures or other more rare situations, but generally it's an MRI if you're coming to see me. And then atraumatic pain is sort of more commonly, this, as I mentioned, is more common without injury. A lot of times patients will have this at rest, especially at night. People describe as like an aching, throbbing kind of pain. It can be, the pain can be only associated with a specific activity. It only hurts when I run. Only hurts when I go down the stairs. It only hurts when I'm sitting with my knees bent, that kind of thing. And you can, in some situations, get sort of recurrent swelling or clicking or catching in the knee with these type of atraumatic type of injuries, but it's not as common. And the things that this usually could be is some sort of soft tissue inflammation, which I'll elaborate on in my next few slides, or it could be cartilage wear or arthritis. So common causes of atraumatic pain, I'll touch on all of these except for the miscellaneous ones, because those are kind of a grab bag of things that are less common. But the iliotibial band syndrome is quite common, patellar tendonitis, hamstring tendonitis, and then the patellofemoral pain dysfunction or anterior knee pain, which we'll dive into, and then arthritis, of course, is very common. And so most of these, obviously arthritis is not necessarily, some of these are not necessarily due to this, but most of these issues are caused by a combination of muscle imbalance or weakness, poor flexibility, and poor body mechanics. So iliotibial band syndrome, or also known as IT band. So the IT band is this long band of tissue that arises from the pelvic brim, runs along the outside of your knee, outside of your thigh, and inserts sort of on the outer side of your tibia, the sort of the top of the leg bone. And it's this band of tissue that you can feel sort of if you rub the outer part of your thigh right underneath the muscle belly of the quad. And so what happens is in situations, very commonly it's tight, and a lot of people will have weak glute muscles. So the gluteals, the big, like the maximus and the medius and the back, and sort of in the back posterior chain muscles are weak, and that causes sort of increased shift of the pelvis as you walk, as you run. The pelvis swings, and it can put the IT band on stretch. And that can cause bursitis, which is sort of where the band inserts on the out as it runs along the outer part of the knee. It can rub on the outside part of the knee, on that bony prominence on the outside there, and cause pain there. And that's sort of usually described as a burning type of pain. And it's usually worse with activity. So a lot of times people will say, when I start running or biking or even walking, it'll start to hurt. And the more I do it, the more painful it is. And then as soon as I stop, the pain dissipates. And so that's a very common presentation for that. Next is hamstring tendonitis. So the common thing that I see a lot is what we call pes bursitis or pes tendonitis. So the pes encephalitis is you have medial hamstrings, which are three muscles on the inner part of your back thigh that run along the inner part of your knee and insert sort of right on the top there, as you see that picture down below, the top inner part of the tibia. And that's called the pes encephalitis, and there's a bursa over that, below that. And if those muscles are tight or inflamed, if you have tight hamstrings, that area can get really irritated, can be quite painful. And a lot of people will express pain with walking, and especially as you go to take a step, when you're actively trying to lift your leg up, you'll have pain there as those muscles fire. Can be quite painful to the touch. A lot of times it's confused with things like arthritis or meniscus tear, but it's lower down. Importantly, it's not on the joint, it's below the joint. And then here's, arthritis and meniscus tears. So, we talk about meniscus tears in the acute setting. Menisci are also cartilage. And so arthritis is, defined as, arthritis is basically sick cartilage or sick joint. And so what arthritis is damage and loss of that chicken bone cartilage that I was talking about. Menisci are also made out of cartilage, and so in arthritis, part of the definition of arthritis is a lot of times you'll have cartilage damage to the meniscus. The meniscus gets more friable, they get kind of less stretchy and flexible and more prone to injury. And so someone who's got arthritis, and I see it on the X-ray, usually 95% of the time, I'm going to say, the likelihood of you having degenerative meniscus tearing is quite high. So even though you haven't had an injury, a lot of times people will come in with an MRI and it'll show degenerative meniscus tearing as what the report is by the radiologist. And that's just the spectrum of, part of the spectrum of arthritis. And so, I have spent a lot of time talking about this, but, unless there's an actual catch or a click or something that's happening with that meniscus tear that's causing symptoms, like it's feeling like something's shifting, it's unstable. I generally try to avoid arthroscopic clean out, so going in with the camera and shaving that meniscus, just because studies have shown over and over again that this likelihood of having a success of that kind of surgery for a clean out to treat pain is about 50-50. And the reason is because you still have the arthritis. You can't get rid of that with arthroscopic surgery. So, generally I try to treat arthritic knees as an arthritic flare. Certainly we've had situations where the patient continues to struggle with pain, not mentally prepared for a knee replacement, and we go ahead and try to do this clean out. And I'd say probably 50% of the time it works. So, unfortunately, it's not a slam dunk every time. And then just a quick note on Baker cyst. I get a lot of this. A lot of times the common presentation will be a patient comes in because they noted pain and then swelling in the leg. They go to their doctor, go to the urgent care, and they do an ultrasound to rule out a blood clot. And then the ultrasound shows no blood clot, but there's a Baker cyst. There's a cyst in the back of the knee, and they send you to me to get the cyst drained or removed. And just to sort of, just wanted to kind of touch on this and try to just educate a little bit on what that is. So it's, as you see that picture there, it's basically a fluid-filled cyst in the back of the knee that communicates with the knee joint. And what this is caused by is swelling or increased fluid in the knee. So, and what happens is the knee is surrounded by a capsule, and the capsule is not stretchy. It's equivalent to kind of like leather. So it doesn't have much give. So there's an amount of fluid that the capsule will hold. And as the joint makes more fluid because it's inflamed or it's been injured, but usually it's because it's inflamed, that joint, that fluid starts to need to go somewhere. So it starts to decompress out the area that has, if there's any like weakness in the capsule. And a lot of times that weakness is in the back of the knee. And so what happens is that the joint starts to drain through that little rent in the capsule. And often it's through a one-way valve, so it can get out, but it can't get back in. And then you get this collection of fluid in the back of the knee. This is very common in arthritis, and especially in arthritic flares. Patients with arthritis, a lot of times will say, yes, sometimes it's bigger, sometimes it's smaller. And that usually either means it's leaking. Sometimes it's a two-way valve, so it can go back and forth, but sometimes it can actually start to leak or even burst, and then it drains into the leg, and that's what causes the leg to swell. So the treatment for this is almost always to address the cause for the swelling. So if you come to me and you have a Baker cyst, but your knee's swollen, there's arthritis in the knee, we're going to treat the arthritis. The reason is because, if you drain it, first of all, there's a lot of big vessels and important structures in the back of the knee that you don't really want to be near a needle. But even if you do drain it, a lot of time it'll just come back, because if your knee's still swollen, that fluid's going to come back. And so you want to treat the inflammation. Now, in some cases with really big cysts, if they're really uncomfortable, really persistent, not getting better, there is some evidence to support going in and draining that and even doing a steroid injection into that area. Usually, I don't ever do that in the office. I'll usually send you to have it done under ultrasound to make sure that no important structures like the arteries and the veins in the back of the knee get injured during that procedure. But I think I can probably count on one hand how many times I've actually referred patients for that. So hopefully that kind of helped clarify some things. And then kind of going into the patellofemoral pain syndrome. So this is what sort of Laura's going to segue into. So this, a lot of times we describe this as anterior knee pain. Patients will come in and will describe this pain under and around the kneecap. It's one of the most common diagnoses that I see in my practice. It's very commonly bilateral. It's usually been going on for years. There's usually not much swelling associated with it. It's more common in women than men, but I do see it in men quite a bit. And it certainly is a nuisance. So with that, I'm going to let Laura take over and we'll go from there. And thank you for your attention.
Thank you. Welcome, everyone. I'm just going to be getting my presentation up here. And okay. All right. So anterior knee pain can have a number of like semantics, catch-all, patellofemoral pain syndrome, as Dr. Urch alluded to, and then also patella tendon issues, which can be kind of captured in the patella tendinopathy category. Patella tendonitis is a more acute version of an inflammation of the patella, and patella tendinosis would be something more chronic. And I'll get scripts from physicians with all kinds of, different, it may just say PFPS on it. It may have something more specific like a patella tendinopathy diagnosis. And the assessment that we do as physical therapists is going to be to get to the bottom initially through a subjective interview and evaluation as to what's happening in the person's life. Have they just recently started a running program or increased mileage or done an activity or event that their body is not accustomed to doing? So the overuse, overtraining are certainly drivers in anterior knee pain. Excessive compression from primarily the quad muscle tightness and or improper mechanics while exercising can lead to this pain at the front of the knee, as well as poor motor control, strength of the quadriceps, the lateral hip, as Dr. Urch alluded to, specifically the gluteus medius, can then as well impact the tracking of that kneecap. Chondromalacia, which was referenced, that softening of the undersurface of the cartilage under the patella, which makes it wear and tear. I'll describe to patients as a Teflon pan that has had, instead of a spatula or a wooden spoon used, it's like gouged with a fork over time and makes that undersurface no longer the smooth surface that it initially was and creates pain. So I think just getting a little bit more in touch with your own body, if everyone in your environment extends your knee out, one of your knees, and just places your hand on that kneecap, you're touching your patellofemoral joint, that's the kneecap itself. It's a triangular shaped bone, they call it an ovoid bone, that has different facets of contact with the femur as it's bent and straightened. And then if you engage that muscle, like you would be tightening, hugging the muscle to the bone, that's the quad set. And that's easier to feel with your knee in full extension or in the straightened position, but you can also do that at various angles. So if you brought your knee back up into a seated position and tried to contract the muscles of your thigh, the quads, you can feel that engagement. So the patella there is embedded within the quadriceps tendon, and it acts as a pulley system, giving a mechanical advantage to the quadriceps for the movements that we do with our legs. In full extension, so again, that position of it being totally straight, it's the least stable position. And therefore, like if I have had several patients over the years be standing at a dog park or by the river and a playful dog comes barreling into them and their kneecap subluxes or moves out, and they're standing in that position with their knee totally straight. Dynamic muscle strength is needed, so that ability to engage your quads protects that to some degree, but no one is really standing having a conversation, engaging their muscles all the time. In full flexion or with the knee bent, the kneecap is or patella is sustaining the most compressive forces in that position, and that makes it most vulnerable to those cartilage injuries on the underside that Dr. Urch referenced. Dynamic muscle length is needed so that there is an additional compression. So if your quads were extremely tight, you would be compressing just by nature of the tightness. So the patella can move up and down, which it does every time we bend or straighten our knee. It also can tilt and rotate side to side. There's less motion in those planes, but it does move in all those directions. It's influenced again by the alignment of our body, as well as the active nature of our muscles engaging. There can be joint restriction that influences how that kneecap can move. So if there is swelling, that's going to restrict the movement of the kneecap. And then muscle strength across the knee, both above and below, impact that ability for it to move. The compressive forces on the kneecap can be very high. So running, as would be intuitive, is going to be a higher force. Doing squats in a loaded fashion, more compressive, especially at those deeper ranges of squatting deeply. So if you picture a baseball catcher in that very deep squat, there's extremely high compressive forces on the patellofemoral joint in that position. The bottom portion of the patella becomes the patellar tendon, and that's like the base of that pulley system where it connects and inserts onto the tibia, the lower leg bone. Stress on that tendon can depend again on that length and strength relationship of your quads. So that's something that we look really close and guide patients in how to be stretching at home. Tendons can sustain repetitive or overuse micro irritations or traumatic more than the macro sudden stress, like a skier at the Olympics going down at such a high speed. That would be a macro stress upon a crash versus the overuse of training. Both patellar tendinopathy and patellofemoral pain syndrome are considered overuse injuries. The repetitive stress that's coming about over and over without that opportunity for the body to heal. Our bodies are always trying to achieve homeostasis, and so that's why having a guided training program and not just going from not running at all to running 30 miles a week, usually the body is not able to withstand those kind of sudden stresses, but can if it's a more gradual process. Understanding how the patellofemoral joint works can make it easier to kind of overcome some of the other disadvantages. Genetics, you can't overcome that. Dr. Urch alluded to females being at having a higher proportion of report of anterior knee pain. Some of that can be from the Q angle or the angle of having the hips in relationship to the knees. Posturally standing with the knees in hyperextension can also predispose. So there are some things that we can do and to prevent, and other things that we have to overcome if our genetics are not on our side. So just alluded again to the genetics and mechanics. The strength of the glutes, the quads, the hamstrings are all really key. We assess this in detail when we start a relationship with the patient in the clinic. So looking at strength of those lower quadrant muscles as well as length of them. If the hamstrings are really tight, quads are tight, calves are tight, those are going to have an impact on the mechanics of the knee. Looking at the range of motion, so how someone with a squat, if they're stuck and their ankle is not allowing them to squat fully, then there's going to be a compensation made elsewhere. So sometimes the knee is the victim, and the issue really can be the driver of the issue is at the hip or the ankle, and so we need to tease that out. So functional movements that we're always looking at are squats, lunges, step ups, and step downs. We take into account balance, because if someone is unable to maintain a aligned position while standing on a single leg, then we understand where some of the weakness, functional weakness, and where we need to focus. And then soft tissue and joint mobility, so massage, mobilization are key. Education, tremendous, really listening to the patient, what motivates them. I had a friend recently go on a surf trip, an avid athlete, cyclist, Nordic skiing. Those motions happen in the sagittal plane of motion, and then getting suddenly on a surfboard for several days at a time when you're in a different plane of motion is going to put different stress. So not necessarily that there is weakness with the individual, but it's a stress that is different and that her body isn't accustomed to in the way that she trains regularly. So looking with using our hands, using instruments, A-stem tools are commonly used in practices, cups to release some of the tightness. Guiding and exercises to address length and strength issues or limitations, as well as balance. We'll use taping to facilitate, so that would be the kinesio tape that we commonly see on athletes, especially this time of year with the Olympics. Sometimes we'll use other type of tape that is more restrictive and keeps the patella from moving excessively in a certain plane. And then there's braces that can be purchased that are helpful as well. Modalities, heat and ice, sometimes use iontophoresis, which is delivering a medication to a specific area. It works pretty well superficially at the knee, and or ultrasound or phonophoresis. Eccentric strengthening is a key component. So that is the ability to lower body weight. That would be a step down. So we talk about concentric and eccentric exercises, and that is very effective for the lower quadrant to train in that fashion. Open versus closed chain exercises, a squat would be considered closed anytime your feet are on the ground or a foot is on the ground, and you're loading, that would be closed, versus a knee extension machine where your feet are up in the air and you're extending. That's kind of the difference. So we educate our patients on that. Focus on improving the strength and motor control of the core. The glute muscles are really key. So just isolating treatment to the quad hamstring is not adequate or thorough. We need to go above and below. Again, pain-free stretching of the quad, managing pain and inflammation, whether that's through NSAIDs or icing, and then really key to modify activity and have a relative rest so that you're guided in a return to your activity in a thoughtful way that your tissue can withstand the loads. So with that, Dr. Urch and I would like to open it to questions, and Olivia will help us to have those come in, and we'll take turns and answer as many questions as we can.
Thank you, Laura. Hey, I just wanted to add, well, two things. First of all, question for you. What are your thoughts on using on the open chain, like quad sets, like the leg extension? I always felt like that was a terrible exercise. And I always tell patients to never do that along with dips. How do you feel about just isolating the quad with those leg extensions?
Yeah, that came up with a patient in clinic today. Over the years, I've practiced within athletic clubs since 2001, and I would say that particular machine has given us more patients than it probably has helped. It's unfortunate because you can see and feel your muscles activate very effectively, but there's a shearing force at the knee, and so it has to be done in the exact right ranges. And I think the way to do it would be if we did have imaging and we knew exactly how the joint surfaces were and we loaded properly. And there's so many nuance that I think it's tricky for someone to execute without it potentially being to their detriment.
Yeah, totally agree. Totally agree. And then before we open it up to questions, I'm just going to say one more thing, just to kind of circle back on treatment for this. I wish I had another slide that I could have put at the end of that presentation. I see, like I said, I see a lot of patients with this issue. And usually the sort of the treatment algorithm for me is, especially if it's untreated, so you've never been to a therapist, it's, just sort of you're seeing me for the first time with this, is I diagnose it, we do the x-ray, it's patellofemoral pain, and, I'll send you to therapy, send you to Laura or someone like Laura. But there's certainly some situations where you end up circling back with me. And I just want to kind of touch base with you on sort of what that might be. So first of all, I definitely, in a lot of situations, especially if there's quite a bit of pain, I think NSAIDs are great. Over-the-counter anti-inflammatories, obviously there's certain things that you want to make sure, if you have medical comorbidities, blood pressure, heart disease, things like this, you always want to check with your primary doctor before just jumping on and starting a full dose of NSAIDs. But in patients where it's appropriate, I think going on a course of an anti-inflammatory is really helpful. And so if you're going to do over the counter, I'll always say, take, anywhere between 2 to 4 PET pills 3 times a day of ibuprofen. So it's depending on what you're taking. Or Aleve is a little easier to dose. You could take up to 2 in the morning, 2 at night. And either way, getting some kind, or I can give you a prescription for something that you can take less frequently during the day, but is just as effective or more effective. But either way, a lot of times in knee, or even especially shoulder, having that on board when you go to see someone like Laura can be helpful, because then you're able to kind of work through some of that and make more progress, as opposed to, well, I go to the therapist, but it really hurts, so I can't do anything. And so I think I will almost always start with that. But a lot of times what will happen is, either you'll get, mechanical symptoms where the knee's catching, clicking, or there's swelling in the joint, or we call it fusions. And it's also helpful for me because I see the patient, I'll see you in the office once every 6 weeks, maybe once every couple of months, versus Laura's seeing you, 1 to 2 to 3 times a week. And so she's kind of like my eyes and ears. And so she knows red flags. Okay, this, something's wrong here. I don't like how you're swollen every time you come in to see me, or I don't like how there's catching or clicking. You need to go back to see Dr. Urch. Or even if you've been in therapy for 3 to 4 months and you've been religious and it's just not getting better. And so those things you'll end up back in my office, and then we start to wonder, okay, is there actually, there's a spectrum of chondromalacia, which is what we call sick cartilage. And, the cartilage, I always describe it as normal, healthy cartilage looks like a freshly Zamboni skating rink. So it's nice and smooth, very, very, very slippery. And then sick cartilage starts to kind of look like crab meat. And so that's why you get that crunching underneath the kneecap, because it's not gliding smoothly in the joint. And so you start to get that popping. And then that popping can become painful, or it really starts to feel like a click. And then we start to worry with, okay, is there a flap? And is that flap causing swelling in the bone? And so that's sort of the spectrum. And in that situations, a lot of times you'll end up back in my office and we'll get an MRI, and that'll be the next step. And then the MRI will show, if it shows cartilage damage, or if there's a flap or, a defect of cartilage, then we can kind of start to address that with some various things like, if it's arthritis, we could do steroid injections, we could do gel injections. If it's a younger patient or patient with good cartilage, but, other than this, whatever's going on underneath the kneecap, then you could potentially go in and arthroscopically clean it out, or, there's different things that we could do. And so that gets escalated. So it's not sort of a round and round and round we go, you're not getting better. Okay, we can't do anything about it. I mean, there are certain situations where it isn't getting better, and then you get an MRI and the MRI is normal, and then you're like, yeah, you just got to keep working at it. And that's really frustrating. But there are certain situations and things to look out for that would potentially have Laura or someone like Laura sending you back to me for another evaluation. Okay, that's all. I'm done. So I guess we could do some questions. I can pull them up. So I guess we can kind of take turns. So do you want to just do that, bounce back and forth? Like I can do one and then you can do one.
Sure.
Or see if there's one called, there's the first one that's coming up is, do you offer artificial meniscus? So it's a good question. So unfortunately, there is meniscus transplant, which is a surgery where you get cadaver meniscus, and that is available in the United States for, you know, and we do that procedure in very specific situations. A lot of these sort of meniscus or cartilage salvage procedures that we do are only really appropriate in patients with not a lot of arthritis. And so, you know, what we'll do, you know, meniscus transplant will be done in a patient who, for example, generally these are younger patients, probably under the age of 50, who have sustained a really terrible meniscus injury that is for some reason not repairable, or a lot of times it's someone who's had an injury that they've been dealing with for a long time that they never had looked at, and then they come in and, you know, I go in and I look and I'm like, well, your meniscus is completely chewed up, there's nothing I can do with it, I had to just clean it out. And then suddenly they've ended up with what we call a subtotal meniscectomy, which basically means that your meniscus is gone. And so that pretty much puts you on a, you know, straight path to arthritis, probably within 10 years or so, especially if it's the outer meniscus. And so in those patients, they're generally, you know, with other things to consider, are good candidates for that type of procedure. But in terms of artificial sort of man-made meniscus, there's a lot of research in it, but nothing's sort of available, especially not in the States. Nothing's approved yet. Nothing's been shown to work well.
So related to the meniscus, there's a question, how does one keep a meniscus tear from getting worse if it's currently manageable? So the worst thing that you can do, and chime in, Dr. Urch, is be in a loaded position, so a squat with twist or rotation. So if you imagine you're squatting, maybe getting something out of the washer dryer and moving it from that squat position in a rotation. So it's like wringing out a dish towel, and that is the torsional or rotational forces are not optimal for the knee joint, especially if the meniscus already has a partial tear in it. I mean, there are a number of other things to avoid, but the deep squat with rotation is always top of mind. Yeah,
agreed. There's a lot of really good questions. I hope we can get to all of these. There's one that says, what might you do to treat light to medium age-related arthritis in the knees? Also, what should we be careful not to do? So to treat arthritis, I mean, a lot of it comes, you know, and I have this spiel that I'll say, you know, you want to start out with, obviously, you know, lifestyle choices. So staying active, you know, as Laura alluded to, flexibility, strength, making sure that your weight is healthy. Those are all sort of the general stuff that all the doctors and therapists will spew at you. So I apologize. But other than that, you know, if coming to me, I definitely think therapy is really helpful. I mean, I still will send people who are completely untreated and have never been treated. You know, if they have arthritis, I'll send you to PT, just because a lot of times it certainly can't hurt. And I've had patients with amazing results, even with terrible arthritis, who don't want knee replacements, go to a therapist and their life is turned around. You know, other things, as I mentioned, NSAIDs, that's sort of always my first line. I'll recommend that as needed for flare-ups. Steroid injections are very helpful. There's also that gel injection that I mentioned, which is like the hyaluronic acid, which is a lubricant that works in about 60% of people, anecdotally, in people more with mild to moderate arthritis, which is sort of alluded to in this question. There's some emerging evidence for PRP injections, which is, you know, you take your blood, spin it down, it's platelet-rich plasma that then you inject. I mean, there's all this, you can have it once or 3 times. There's all these different protocols you can follow. It's still considered experimental in the sense that no insurance has approved it, so it's all out of pocket. But there's been some promising in the sense that it's been shown to work as well, or maybe a little bit better than gel injections. So all these things are kind of Band-Aids. You know, it's just basically symptom treatment to try to prolong the life of your knee. And then being careful what not to do. I mean, honestly, you just have to listen to your body. A lot of times I'll say, you know, if you have arthritis, probably running or high impact sports are not the best thing for you. You want to do low impact sports like biking, swimming. Those are very good. Walking is generally pretty good, but those are kind of the things that you probably want to avoid, really.
So there's a question, when you want to, let's say, when you run or want to start running, how often should you run and for how long to avoid future pain and injuries? And that is so many variables within. There are some really good return to run programs that we will guide our patients with that have a few minutes of walking following a dynamic warm-up and then running, and it's a kind of alternating walking and running, and it may seem slow and tedious, though over many years I have not had patients fail with that program. Those that just say, okay, I feel ready, and they're going to go do the river loop again, tend to get into a little bit more trouble. Both Dr. Urch and I have a history of running and enjoy running, but respect how challenging that can be, the load, the degree to which your glutes are firing, the core strength, the overall body mass that you have when you're running. Those are all variables that make it difficult. So it's a highly individualized, but being able to listen to your body and small increments. So we typically wouldn't say any more than if you're running, say for 20-25 minutes, you wouldn't increase that by more than 10 minutes and have a day off in between, so that you can really assess how does your body feel after you've returned.
Okay, so a couple of other things. So just to confirm, there's someone asking about, was it the leg extension machine that we suggested not using? And the answer is yes. Stay away from the leg extension machine. What else? Let's see. And then question about patellar tendon issues, knee brace. I think, I mean, being someone that has struggled with this before, I mean, the only thing that I found that could be a little bit helpful, but I'm not sure that it's actually helpful in the long term, is that the patella strap. I mean, I don't know how you feel about that. It's like a little strap that you put underneath the kneecap around your leg. And I use that all the time when I was younger, because I had the same problem. That seemed to help, but honestly, that's probably just a temporizing thing. You really want to actually address the underlying issues. I mean, probably agree with that. A lot of good questions, a lot of long questions.
Yeah, I know, I'm reading a couple. There was a question about massage or manual therapy techniques, and there are a number of well-trained massage therapists in town that would be able to get in and release. That's, if you look at how to approach the body, that would be one area of it. Certainly looking at the strength-length relationship, making sure soft tissues are optimized. So I'm absolutely a proponent and refer patients out for deep tissue work regularly. You can also use the foam roll, and some patients order their own cups. So there's many ways, once you're guided in the specific tissue that is needing to be released, in how to approach that.
Yeah. Okay. And then there's another question about, so I mean, just kind of touch on it. First of all, there's a question about if the center has a class for all over body strengthening. Unfortunately, we don't offer any classes here at the center, but you know, I think that, you know, and I'm sure actually Laura probably could attest to, there's a lot of really good trainers in town to help provide just overall body strengthening to get you ready for running. There's even running coaches that can kind of get you there. I don't know if you know of any specific classes that you would recommend, Laura. I know the guys that I train with are great at Rise and love them. I don't know, any other suggestions for kind of an overall body strengthening class that you can think of?
Yeah, I mean, there's more studios than I would want to stay within this, and we do work closely with them. So especially if you have worked with a physical therapist, and they can then directly communicate on your behalf with your trainer, the level of specificity of the training can be elevated a bit through that partnership.
Yeah. Okay. So let's see. A couple of years ago, I injured my meniscus. I had the knee drained and a steroid shot. It's been okay for almost 2 years. It lately has been acting up, a sharp pain every once in a while. Is this common? And there was so I mean, the bottom line is, it's hard to sort of answer this question definitively without sort of understanding more about what the knee looks like on x-ray, what the meniscus was like. But I can say that, depending on the type of meniscus tearing, especially if there was some arthritis involved at the get-go, if over time, that, especially if it's a bad tear in the meniscus or a tear that sort of really impacts sort of the integrity of the tissue and takes away the meniscus ability to push in the joint, it could certainly tip you over to where you start to have more symptoms for arthritis that might be progressing. So that's kind of the first thing that jumps into my mind when I hear, yeah, I had a meniscus tear a few years ago and now it's getting worse, especially if it hasn't been any new injury. If it's an occasional sharp pain once in a while, it's probably not necessarily something that needs to be immediately seen, but if it's consistent, you've been experiencing swelling, it might not be a bad idea to get it looked at again. Because the one thing you don't want is a constantly swollen joint, because the swollen joint is an inflamed joint, and inflammation can actually lead to progression of arthritis. So you want that to calm, to sort of get rid of that inflammation. Anything else? Oh, there's one. I mean, is laser effective with PT? I mean, I don't know. What do you think, Laura? Do you use laser very often?
I have some patients that use it, and some people feel it's really helpful, and others it's more difficult to determine. But I don't deter patients from trying it, especially for a more acute, not chronic situation.
Mm-hmm. Mm-hmm. What exercises are good to do to minimize the risk of a knee replacement? So that's a great question. I mean, I think it's again sort of circling back to low impact. So if you're someone that's struggling with arthritis already, if you're kind of thinking about a knee replacement, then low impact activities like walking, running, and really not even that, but also focusing on stretching, because flexibility around the joints is so important to optimize the mechanics and the efficiency of the joints. So those are all very good. If you're someone who's just thinking about the future and concerned about the future, again, I think it really comes down to just maintaining, as Laura was talking about in her presentation, so good length in the muscles. So strength and flexibility around joints, and obviously maintaining a healthy lifestyle. And I think cross training is very important to avoid sort of falling into the overuse trap, because you want to sort of train in all planes and not just, I'm just going to bike forever and ever and ever. So that's very helpful to kind of change things up and keep your body guessing, if you will.
Yeah, the looking at the strength of other supportive muscles, specifically the glute. So if after we sign off this evening, you go to get out of a chair, off the couch, and you assess yourself in what muscles am I using to get myself up, and you don't feel that your glutes are helping get you out of that seated position, that would be one place to start, because we don't want to become quad dominant and overly reliant. While we want the quad strong, you really want to harness the strength and power from the other muscles as well. So it's so individual, then that's what makes the work that we get to do in partnering with patients rich, because we're investigating as to what's specific to that individual, and then able to do that specific assessment of the musculoskeletal complex to figure out dynamically what is that person's bias, or are they overloading on one side and not really firing the other side habitually without awareness, and sometimes subtle tweaks can make a big difference.
Couple other questions. So I had a meniscus repair back in October and my knee is still in pain. The doctor said they found some arthritis. Do I need to get a referral to go see the specialist again, and what can I do? So just to clarify, there's a difference in semantics if you're repairing a meniscus versus a meniscectomy, which is a clean out. And I'm just saying that because I think a lot of people use them interchangeably, but they're very different. So if you actually did have a meniscus repair, which means that the surgeon went in and sewed the meniscus back together, and usually that means you're on crutches for 6 weeks and therapy is a lot more extensive. In that case, that usually we do that in the setting of very minimal arthritis. If you have arthritis, it's very unlikely that your meniscus is going to get repaired. More likely it's going to get cleaned out, just because we know that meniscus repairs in the setting of arthritis don't do well. So, but if you did have a repair, and you're still having pain in that area, then it's probably not a bad idea to get it looked at, just in case walking on it and you've gone through all your rehab, because the tears can recur, and so certainly that would be a good idea to get back in and see your surgeon. However, if it was a clean out, and it's, and you're having pain, it's very possible that it's due to the arthritis. And again, it just depends on how symptomatic and how much discomfort you're having. So if it's just a little bit of pain, you could certainly try to self-treat with a little course of an anti-inflammatory if that's appropriate for you, and sort of activity modification, which means, rest and, depending on how active you are, maybe not doing impact things, or even hiking on uneven surfaces in the setting of arthritis can really irritate the knee. Walking on sand can be very irritating. But if all those things aren't helping and it still bothers them, and you find that you're not sleeping well and you can't do things and you're really mobilized, then certainly getting back in and getting it looked at again is reasonable.
There's a question about using a rowing machine for exercise, and there's specific to the lower quadrant, provided that it's pain-free, that can be a really effective exercise that is low impact. Many people don't know posturally, and there's some other nuance with regard to rowing machine, but I wouldn't have, as long as it's a pain-free activity, I wouldn't have any qualms about that being used for someone with a knee arthritic situation.
Mm-hmm. Yeah. Yep, I agree. It's a great workout as long as you do it correctly. It can really hurt your back. So let me see, there's a question here. I've been trying to stave off a knee replacement. What is the oldest age in a healthy adult that you would replace it? That is that's a good question. Honestly, especially in this day and age is really just a number. So you have to really approach the patient in the entirety and sort of really have a discussion. Knee replacement is elective surgery. So, I always say as a surgeon, surgery can make you better, but surgery could also make you worse. So it's really individualized, but I think it just depends on what your risks are. And, you have to have sort of a realistic discussion with your surgeon, with your primary doctor, depending on what your comorbidities are. But, I've had patients who say, I can't, if I'm either going to have this replaced or I don't want to live. And so that's obviously, in that case, you have, so there's really no age, in my opinion. It's sort of like you approach each patient individually as a whole, and you have a full discussion so that the patient can make an informed decision about their life. Because if your quality of life is impacted so much that, you're unhappy and getting depressed, then, then maybe the risk of doing a knee replacement is worth it. So.
There's a question about what can you recommend to treat IT band syndrome following knee replacement. So any IT band syndrome is uncomfortable and can persist. It goes back to the things that we alluded to earlier on the slides of looking at length and strength. It's a band. IT band is a thick band of fascia, so it's not a contractile tissue like the quads or hamstrings, but does have muscles up at the hip inserting into that band of fascia. So looking specifically at how those are firing, if there is adequate strength and endurance of those muscles, and then soft tissue techniques and using foam roll or a roller that you can use with your hands to bring increased circulation to that area. And then activity modification too, to look at, is there something specific that is making the IT band syndrome persist?
Okay, one kind of a long one, but I think probably a good one to discuss. So this woman put in sort of the read of her MRI. So MRI shows grade 4 chondrosis of the tibia, grade 3 chondrosis of the patella with edema, so a lot of medical terminology. And then there's some cartilage fishing and short course of an anti-inflammatory, no walking, hiking, allowed for all symptoms to be improved. But then as she started walking 3.5 to 5 miles 3 times a week, the symptoms returned. So, you know, just to be clear, when the MRI reads grade 4 chondrosis, that's basically full thickness cartilage loss on your bone, which basically is arthritis. So the two are interchangeable. So what I'm reading, that MRI report, which is, I'm assuming is sort of kind of what the radiologist reported, is that you have arthritis in your joint on the inside of the knee and underneath the kneecap. And the edema in the tibia, which means that there's just swelling in the bone, which tells me that that part of the bone of the joint is being overloaded because there's not enough cartilage or cushioning to take the force when you're walking. And so it makes sense that when you unload the joint, which means you stop walking, you do anti-inflammatories, it gets better, then you start walking and it gets worse. So answer is, I think therapy definitely would be helpful, also for the various reasons that we've talked about. There's certainly other things that you could do to help that. There's special braces, especially if all of your arthritis is primarily in one part of the knee. There are unloader braces you can use to help reduce that inflammation in the bone, because a lot of that can take, you know, once you get swelling in the bone, it can take 3 to 4 months, even more, to go away. And as you start walking, it'll come back. And so there's special braces you can use to help unload that, so you can, to sort of help you stay active while the bone is healing. But you know, the short answer is certainly therapy could be helpful in building up strength, but it wouldn't really address that edema that just has to sort of be addressed separately.
We're right at 7. I don't know. I think we covered most of the general themes of, and just to be respectful of everyone's time. Thank you. I wish that we were all able to be in person and see each other's faces, but there's an advantage, I suppose, to no commute, and for those that are in their homes. And yeah, we appreciate you showing up and engaging with us within this platform.
Yeah, thank you so much, everyone. Hopefully it was helpful. And thank you, Laura.
Thank you.